Good evening, ladies and gentlemen. It's my great honor to attend the wonderful conference. My topic today is about the application of transient elastography for the management of fibrosis and hepatic steatosis in China. I'm Jian-Gao fan from Department of Gastroenterology, Xinhua Hospital, Shanghai Jiao Tong University. This is my disclosures. According to the Global Burden of Disease Study from 2012 to 2017, the global liver-related deaths has increased 11%. Chronic viral hepatitis remains the most common cause of liver death. NAFD is the most rapidly growing contributor to liver mortality and morbidity. Over 15% of global deaths due to cirrhosis and 73% of global deaths due to liver cancer occurred in Asian regions, most of them from China. Hepatitis B remained the most common type in mainland China, and hepatitis C is the second reason for liver cirrhosis and liver cancer in mainland China. Recently, prevalence of chronic liver disease increased over the past decades. And non-alcoholic fatty liver disease increased the most obvious, and NAFD is becoming the largest liver disease in mainland China, with the epidemic of obesity, type 2 diabetes, and metabolic syndrome. Over half numbers of patients belong to NAFD, and more chronic hepatitis B, hepatitis C, and chronic liver disease have obesity or metabolic disorders related fatty liver disease. Overall prevalence of NAFD was 29.6% in a meta-analysis according to studies from Asian countries. NAFD prevalence increased over time. Therefore, prevalence of NAFD and NASH are higher than those in Europe and North America. The situation is true in South America. Global, around 14% of the NAFD population are not obese, and nearly 20% are lean, with highest prevalence in Western countries. Lean NAFD is a stage of metabolic adaptation and progressive condition. According to our recent meta-analysis, non-obese NAFD is becoming prevalent and also associated with type 2 diabetes and metabolic syndrome. The polar proportion of NASH and advanced fibrosis in non-obese NAFD were less than those in obese NAFD. However, the outcomes of lean NAFD is similar in those of patients with obesity. Lean NAFD can progress to steatohepatitis, advanced fibrosis, cirrhosis. hepatocellular carcinoma, and cardiovascular disease, and actual liver cancer. The presence of significant and advanced fibrosis was independent facts for outcomes of NAFD regardless of body mass index. BMI-driving approaches for NAFD should be replaced by better diagnostic tools emphasizing assessment of metabolic disorders and advanced liver fibrosis. The natural history of NAFD in aging is similar in Western countries. More and more NAFD patients progress to cirrhosis and HCC through nursing and liver fibrosis. Compared to no fibrosis, unadjusted risk increased with increasing stages of fibrosis in liver biopsy-proven NAFD, including all-cause mortality, liver-related mortality, liver transplantation, and liver-related events. Advanced fibrosis is the only predictor for better outcomes of NAFD, regardless of steatohepatitis and overweight and obesity. Therefore, the nomenclature of non-alcoholic fatty liver disease was updated to metabolic associated fatty liver disease last year. Diagnosis of MAFD should be based on the presence of metabolic dysfunction, not the absence of other conditions. MAFD can coexist with other liver disease. Hepatic steatosis is the risk factors for fibrosis and cirrhosis in patients with other chronic liver disease. Recently, the Asian Pacific Association of the Study of the Liver issued clinical guidelines for the diagnosis and management of MAFD. They are stressed the importance of risk of advanced fibrosis assessment in patients with MAFD. Fibrosis is very important to progress of liver disease in MAFD patients. We should use non-invasive scores and transient elastography for monitoring fibrosis in patients with MAFD. According to ISO guidelines, biomarkers and fibrosis scores such as transient elastography are acceptable and non-invasive and are used to identify low-risk cases of advanced fibrosis. Sequential combinations of non-invasive markers, including FibScan and FibTouch, with a lower cutoff to rule out advanced fibrosis and a higher cutoff to rule in cirrhosis, can reduce the need for liver biopsies. In 2012, we undergone FibScan for diagnosis of hepatic steatosis and fibrosis simultaneously. You can see CAP is good enough to diagnosis of hepatic steatosis to differentiate mild to moderate to severe hepatic steatosis. The cutoff values of CAP for diagnosis of steatosis is independent of the etiology of chronic liver disease. And body mass index, skin capsular distance were the important influence on the performance of CAP for diagnosis of hepatic steatosis. We should best clarify the cutoff values of CAP for diagnosis of hepatic steatosis according to skin capsular distance. In liver biopsy proving chronic hepatitis B, CAP is good enough to detect mild hepatic steatosis. And CAP is better than hepatic steatosis index and ultrasound for diagnosis of hepatic steatosis in chronic hepatitis B patients. Cutoff values of CAP for diagnosis of moderate to severe hepatic steatosis in chronic hepatitis B were proposed. Most of studies suggest over 216 dB over M is good for diagnosis. According to 2,735 individual patients data meta-analysis of CAP for hepatic steatosis, you can see different cutoff values were suggested for diagnosis of hepatic steatosis, moderate hepatic steatosis, and severe hepatic steatosis. We should, according to the cutoff values of CAP, for modify the diagnosis accuracy of liver stiffness measurement for liver fibrosis, because higher CAP might influence the liver stiffness measurement. According to our study, moderate to severe hepatic steatosis leads to overestimation of liver stiffness measurement in chronic hepatitis B patients without significant fibrosis. However, it cannot influence ALSM for diagnosis of fibrosis in hepatitis B patients with significant and advanced fibrosis and cirrhosis. High CAP values may not be associated with poor diagnostic performance of ALSM in staging liver fibrosis in chronic hepatitis B patients. We can combine CAP and M16.5 of cytine keratin 18 for diagnosis of non-alcoholic steatohepatitis to reduce the need for liver biopsy in patients with NAFD. Recently, more and more in liver touch transient elastography by Wuxi Healthcare were used in mainland China. It can detect fibrosis and steatosis similar to FibroScan. Liver touch applies transient elastography technology to assess the level of liver fibrosis and steatosis with excellent examination results. Innovation based on tracing the elastography of fiber-touch, multimodal fibrosis probe, multi-channel tissue information scanning, dual display of multiple results on one screen, high-end color Doppler ultrasound of fiber-touch. To investigate the efficiency of FibroScan and FibroTouch in ARSM and CAP through a comparative analysis, we enrolled 1,621 patients with suspected liver disease who simultaneously underwent FibroScan and FibroTouch. The success rates of FibroTouch was significantly higher than FibroScan, and FibroTouch has a significantly shorter duration of a single detection, lower number of times of a single detection, and lower ratio of interquartile range to median of CAP in the same patient. The ARSM values of FibroScan were significantly correlated with those of FibroTouch. The situation is similar of the fat quantification of FibroScan and FibroTouch. Based on the duration and number of times of single detection, success rate, and the stability of fat quantification, FibroTouch seems to have a better detection efficiency than FibroScan. The detection values of FibroTouch and FibroScan can be calculated with regression equations. Recently, a study from Professor Jian-Gao validated the operational and diagnostic performance of FibroTouch for liver fibrosis in liver biopsy proving chronic hepatitis B. All had achieved at least 10 successful ARSM, resulting in a success rate of 99% and reliable evaluation of 95%. The ALC for the ARSM was over 0.8 for fibrosis stage. The diagnostic accuracy of ARSM was superior to that of APRI, FIB4, and some other index in staging fibrosis, significant and advanced and cirrhosis. We can diagnose significant, advanced, and cirrhosis according to the optimal ARSM cutoff values. FibroTouch has a high success rate and good reliability in staging fibrosis in chronic hepatitis B. The diagnosis accuracy of ARSM was superior to that of GPR, APRI, or FIB4. Recently, we recruited 237 liver biopsy proving chronic liver patients undergone FibroTouch and liver biopsy simultaneously to evaluate the diagnostic performance of ultrasound attenuation parameter and ARSM for hepatic steatosis and fibrosis. The success rate of FibroTouch examination was over 96%. The ALC of UAP for diagnosis of steatosis, moderate steatosis, and severe steatosis were over 0.88. and the cutoff values were 244, 269, and 296 dB per meter, respectively. They also have good diagnostic performance for significant fibrosis, advanced fibrosis, and liver cirrhosis. AISM was positively correlated with degree of fibrosis and NS score. UAP, ultrasound, attenuating asing parameter by fiber touch was positively only correlated with biopsy proving hepatic steatosis. Diagnostic performance of UAP for steatosis was significantly superior to that of hepatic steatosis index. Therefore, fiber touch is suitable for clinical evaluation and monitoring of fibrosis and steatosis in suspected patients with liver disease. In summary, clinical advantages of transient elastography by FibroScan or FibroTouch includes non-invasive, rapid, accurate, and quantitative simultaneous for fibrosis and hepatic steatosis. It can used to only screen, only preventing high-risk groups, only diagnosis of suspected liver patients, and monitoring treatment response of fatty liver disease. More and more new technology advance of FibroTouch is provided by WuXi Healthcare. We can see this device widely used for only screen, only diagnosis, and only evaluating treatment response of chronic liver disease. Thanks for your attention. Welcome to Shanghai, China.